John Todaro. I'm one of the presenters. I'll be presenting with Dr. Nerina Stepanovsky. As you can see, hopefully everybody has the first slide up. I am the Assistant Director of the George and Marion Miller Center for Experiential Learning and Simulation at the College of Nursing at the University of South Florida in Tampa, Florida. And Dr. Stepanovsky is the recently retired program director from the St. Petersburg College EMS programs and is currently the owner and lead consultant for Caduceus Educational Consulting. And there's those great commercial pictures of us for everyone to look at. Thank you for taking the time to be accepting questions. If MC office will be collecting those, and at the end of the presentation, we will try to answer as many on time. So the next thing is disclosures. Just not a whole lot for either of us to disclose. For me, it's important that I disclose that I'm the chairman for the integration committee, for the simulation integration committee for NEMC, which means that I manage many of the simulation projects that NEMC is directly involved in. Dr. Stepanovsky in the past has been a consultant for the AE, which, as you know, is one of the providers of high fidelity simulators in various fields. So those are really the only disclosures either one of us have. And we're going to move to a review of the literature, and I'm going to turn that over to Dr. Stepanovsky.
Thank you, John, and hello, everyone. Thank you so much for joining us today. As John and I were preparing for this today, I noticed that there is tons, and I do mean tons, of information and peer-reviewed articles on simulation. And I think I found probably 150 or more in the last 3 years. So everything we're presenting to you today, the oldest article is 2015. But there's many, many articles about there using simulation, not just for initial education, but also for verifying competency. And it crosses all mediums. But guess what? Unfortunately, there's not a whole lot in EMS. The majority of the articles that I cited, and you'll see that list at the end, comes from medicine, of course, nursing, and the military, and even education. And Australia produces a ton of information for EMS and also for simulation. So there's a lot to look at, and I listed the last, probably I think 10 or 11 of them that I thought were most salient to what we're going to be discussing today. So I'm going to start talking about some of these just to kind of start out and give us an idea where we're coming from. Again, McGrath in 2017 cited that counting all the health professions, we actually lag behind most other professions, including aviation. And for those of you that are familiar with crew resource management, you know that started in aviation. So aviation has used simulation and continues to for a long time. Wow, that's kind of interesting. And of course, military, so we'll lag behind in simulation. So
and one of the things that, I'm sorry, Dr. Stepanovsky. One of the things that I kind of want to reiterate is anybody who's had the opportunity to look at the study done by the NEMC simulation team, that kind of verified that from the perspective of EMS, that we are kind of lagging behind. We're lagging slightly behind even nursing, who the National League of Nursing several years back took a big push to push simulation. So it is coming to its fruition now in EMS, and we are, looking at how we can make it work much better. I'll turn again back over to Dr. Stepanovsky.
Thanks, John. And again, several articles that I looked at actually talks about the benefits of using simulation. Of course, we know how great simulation is for teaching, but also to assess the work of interdisciplinary teams. I'm going to talk about that a little bit more later. There was one article even that talked about using simulation to onboard new graduate nurses program, and that's one of the last things I'm going to talk about later. And I thought, wow, wouldn't this be great if we do this in EMS? So more on that later.
Well, so and we know that anybody who has had the opportunity to deal with agencies or trying through orientation, what a hassle that can be in getting them to the proper level of competency. And the research on the nursing side has shown that this process of creating an internship really speeds up the process and gives a more competent nurse at the end of that internship. And much of that is done using simulation. And there's tons and tons of research out there, especially through the National League of Nursing. Speaking of research, for a moment, we just want to talk a little bit about the super study. Now, this was the study that MC did on the use of simulation in paramedic education. It was published in Pre-Hospital Emergency Care in February 2015. If you're not familiar with it or haven't had the opportunity to maybe get a copy of the article, you can go to the NEMC website. Under National EMS Resources, there's a tab that says Simulation, and actually all of NEMC's printed simulation materials are under that tab, but the first one is the super study. So it was done using a cross-sectional survey of the KHEP accredited COAMPS paramedic programs, and there were a lot of conclusions that came up. We're just going to talk about a few because we don't want to take up the whole time, but it was kind of interesting to note that a vast majority of the programs that were surveyed had a wide variety of simulation resources, everything from the standard skills type mannequins to super high fidelity mannequins. But what we really found interesting and what correlated with the National League of Nursing study when they studied nursing programs and their use of simulation was that about 31% of the respondents said that they have simulation resources that were either sitting idle or were completely unused. Now, much of that is attributed to a couple of things. The first that it's attributed to is this equipment is purchased sometimes on grants, sometimes with specialty money or donated, and training doesn't always follow actively. So a lack of training of faculty and staff was the most commonly cited reason in the super research for the lack of use. It's kind of interesting, 87% of the faculty had training, but it was training from the manufacturer on that specific piece of equipment. So if they were, bought a CAE mannequin, they bought a Leardall mannequin or a Mard mannequin, whether it was medium or high fidelity, they got the training from the manufacturer. It was on that product. It wasn't necessarily on using simulation, how to integrate simulation. And we were very surprised to find out that about 19% of people who had mannequins had no training at all on how to use them, so hadn't purchased any kind of training. The other thing that was really interesting about the survey was about 78% of the respondents said they wish and thought they would really like to use simulation more, and they'd like to increase the use of that simulation in their programs. So, when you look at that process, it's very interesting. And again, the survey had a lot of research in it, and please, if you haven't had the chance to take a look at it, download it. You can get some more information. This was just kind of like the highlights. So in the survey, we had some interesting processes about what were the goals for people using simulation in their programs, whether that was an initial program or a continuing education program. Now, keep in mind, with Super, we surveyed primary programs, but we've, since then had a lot of conversations with people about continuing education and new employee onboarding and how that can be used. So patient assessment, critical thinking, and problem solving are the primary goals of using a simulation. You want to be able to assure that you can do these things because we want our students to be able to critical think. We want them to be able to problem solve. So interestingly enough, at the point of the survey, we found out that safety and crew resource management were probably the least used for simulation. Simulation was used the least to do that then. Now we since have seen an uptake in that. A lot of agencies are starting to move so that, and we've seen other research projects that look at that. So about 44% of the respondents in the survey have personnel to support specific simulation, meaning that they had personnel who were trained to use the specific simulator they had or the skills setups that they had. But that's a pretty low amount when you start thinking about that. And that didn't correlate well when respondents reported that they felt like simulation skills, they wanted to use simulation skills more frequently, especially in areas where they were having difficulty with field or clinical hours. We all know, anyone who runs a paramedic program or any training officer who is running a training division for an EMS agency knows that there are certain areas like airway that we frequently have to look at, and it's difficult to get field or clinical hours time in the OR these days. And with some of these simulators, we can replace some of those hours. We certainly don't want to replace 100% of them. And the research holds up to that. When you look at outside research, for example, the NON research shows that their research shows that up to about 50% of certain clinical hours could be replaced by simulation with no negative effect on the students' abilities, and in many cases an increase in the quality of the students' abilities. So can we go to the next slide?
Yes.
Yeah. So, the next concept that we want to talk about when we talk about the use of simulation and whether you're using it in a primary or continuing education setting is the fidelity. Now Kim and her group, Kim et al. in 2016 did a really good survey, a really good research project on simulation fidelity and its effectiveness in nursing education. And there were some great results to that actually, if you think about, can correlate into EMS. We learned that simulation-based education is very effective in the learning domains. Things like the psychomotor domain, high fidelity simulation, and even medium fidelity simulation, but especially standardized patients, allowed programs to increase the effectiveness of their education in the psychomotor domain. And that's kind of obvious, but even what it also showed is that hybrid simulation or low fidelity type series were not near as effective as we see with high fidelity and medium fidelity. And those that know me know I'm really big on the use of standardized patients because of that assessment process that can be done with a live patient. Interestingly enough, high fidelity simulation scored the highest in this research regarding the cognitive domain. So not only does high fidelity simulation affect psychomotor domain, but it also directly can affect cognitive domain. And as we start walking through and say, well, we need to talk about affective domain as well, again, high fidelity simulation came in first, even ahead of standardized patients, which is kind of interesting when you think about it. It's real standardized patients are real people talking to them. But we see that affective domain get better with simulation. So psychomotor, cognitive, affective domains are all, based on the research, effective in taking the fidelity of that high fidelity simulator and converting it to improving those to the students. I'm going to let Dr. Stepanovsky take over here in a minute. Okay.
And then again, remember, folks, that everything that applies to initial training also is appropriate for continuing education, remediation, and even onboarding new employees. So thanks, John. What I want to talk about now is I want to talk about an article that is by Young et al. From 2016, and he did a study on the use of simulation for initial and refresher training for anesthesiologists and nurse anesthetists. Now, we all know that one of the big things that we face, one of the big blocks that we face is intubations. And of course, COAMs, for those of you that are with initial education paramedic programs, know that COAMs is struggling with this right now, where it's getting harder and harder and harder to get students into the OR. But not just that, we have the same issue with our employees. Let's say you have a failed intubation or a bad intubation. What are you going to do? How are you going to remediate that provider? Well, you'd love to send them to the OR, right? If you're hospital-based, sometimes you can do that. But if you're not, it's virtually impossible to get into most hospitals. So I found this article very interesting. If you're familiar with the Institute of Medicine report, remember, they cited that there's increasing patient errors. And because of that, we really need to focus as a vocation on the need to improve patient safety and increase the quality of care. And again, remember, that's pre-hospital as well as in the hospital and in rehab too. So because of that, the use of simulation has become more widespread. If any of you are familiar with CAE, used to be MEDI, if you remember way back in the late 90s, the human patient simulator actually was started at the University of Florida as an anesthesia trainer. So that's kind of where it got its start. Young et al., their conclusions were the simulation-based education is both valid and superior to traditional methods. And when they're talking about traditional methods, they're kind of talking about the, okay, watch, I'm going to show you how to do this, and then you do one, and then you teach somebody else. Well, guess what, folks? It doesn't cut it in today's world anymore. We are in a very litigious society. Airway is one of those big things where if you get it wrong, there are dire consequences to the patient. And intubation in many parts of the country now, endotracheal intubation is actually becoming one of those low frequency, high, I'm forgetting the word here, John, help me. It's low frequency but high impact or high liability skills because we're going to supraglottic airways and other things. So we just can't use the see one, do one, teach one anymore like when I was in paramedic school a few years ago. They did specifically deal on one segment of airway management, and of course that's, I think, all of our worst nightmare, and that's the CICV, can't intubate, can't ventilate. Any of you had dealt with that before? Oh, what a nightmare. And again, I call that the perfect storm. Now, we're in the hospital, but what about us when we're out in the street or in the field and we don't have the resource of calling for anesthesia or sending them to the OR right away? So again, they found particular success in managing difficult airways with simulation. They found it particularly effective because, again, you really can't wait for a patient to present with a difficult airway and say, okay, everybody come see this and how you're going to management. Because, again, we don't know. There it is, high risk, low frequency. That's what I was trying to think of. And one of their associates, Kuduvali, showed that simulation training significantly improved anesthesiologists and nurse anesthetists' ability to manage a difficult airway. But the thing that I found of particular interest was by using simulation training, adherence to the difficult airway process, or in our world protocol, can be sustained for 6 to 8 months after simulation training. And I thought that was very, very significant. Now, when's the last time that you or agent reviewed difficult airway and actually had the chance to perform one? I don't know. For me, I can tell you it's been a while. But with the use of simulation, we can recreate those high-risk, low-frequency events, and people can practice on them knowing that, okay, if you have a bad outcome, unfortunately, the mannequin dies, right? But we can revive them. And you can learn from your mistakes and nobody gets hurt. That is what I love about simulation. Yes, people feel bad, and I'm glad when my students feel bad because, you know, they killed the simulator. But the thing is, it's a safe learning experience. And John, you want to jump in here? That's kind of why I love simulation.
Well, and the whole process of the safe learning experience and the ability to immerse your students, whether they're your employees or whether they're initial students, you know, to immerse in an environment where you can challenge that process. Simulation can do that, whether you're using high fidelity or whether you're using standardized patients. And in the airway management process, the high fidelity mannequins that are out there now are phenomenal. Now, a lot of us can say, well, they're very expensive, and you know, but there are even low and medium fidelity skills mannequins that can allow you to do this kind of high risk, low frequency procedure assessments and practice to prevent that perfect storm, as Dr. Stepanovsky was talking about, where, you know, I can't get them intubated, I can't ventilate them, and nothing's going right. Well, when that happens with a simulator, whether it's medium fidelity, high fidelity, it can be redone. You can look at the process. What's the student doing? What's their process in getting ready to do the airway? How are they doing their sequence? Are they missing a step, or are they adding a step that's causing this problem for them that is interfering with their ability to ventilate or intubate? You know, and for agencies, especially for continuing education, for agencies to maintain competencies and be able to document those competencies on a continuing basis, simulation is one of the best ways to do that, as the research shows.
One of the other things that this group of researchers looked at is they also looked at cricoid pressure. Now, again, if you're familiar with the the 2015 guidelines. We know that we don't use cricoid pressure in the field as much as we used to, but they do in the OR. And they also used simulation, high fidelity simulation, to correctly teach and reinforce concepts for their anesthetists and their anesthesiologists. And they also used it for retrograde intubations and things like that. So I found this article to be very, very interesting. And again, because airway is one of those difficult things for us to really make, help our students and our colleagues be competent in, I think that this really proves the point.
Well, and we all know airway is a big issue in EMS. We've read some of the previous research of, should medics, shouldn't medics intubate? Should we be using endotracheal tubes, or should we be using some of the laryngeal airways or some of the other airways that we used to call rescue airways out there? And, much of that is based on what is perceived to be the inability to maintain competency. When you have a process whether it's in your agency or in your program, that allows you to help your employees or your students maintain competency, then that feeling of, well, if we can't use an endotracheal tube, we should this. And many medical directors are fond of some of these new airways, and many are not. So, it's going to be an agency-specific thing, but the ability to be able to practice the procedure and maintain competency using simulation is a major, major advantage, whether you're a student or whether you're that field advanced EMT or medic out there who's trying to, maintain their skill level.
And again, what I found so interesting was these are anesthetists and anesthesiologists who intubate and insert airways every day, every working day that they have. And they only retain this skill for 6 to 8 months. So how long do you think that our paramedics and our advanced EMTs are going to be able to retain this skill, when they rarely do it at all? So again, to me, this really points to not only a huge benefit of simulation, but the importance of continuing education, and practicing those high-risk, low-frequency skills on a regular basis. So another article then that we reviewed was talking kind of about training your replacement, is what I entitled it. And Jones et al. In 2017 talked about succession planning for hospital nurses. And so what does this have to do with EMS? I'll get to that in a minute. But you'll see a lot of these, I think, really fit us too. First of all, she says the word nursing workforce is aging. Well, what about us? It's the same thing. Patient acuity is rising. Sure, people are sicker and sicker. A lot of times they wait to go to the hospital to the last minute. But remember, the hospitals now, a lot of things are done as outpatients. So the type of patient that you're seeing in the hospital is sicker than they used to be even 10, 15 years ago. And hospitals are having increasing challenges recruiting competent nurses. Are any of you having issues trying to recruit competent EMTs, AMTs, paramedics? I think so. I know it can be regional, but in parts of Florida, we're having that issue too. I found this interesting. There's a projected national workforce shortage of 1 million nurses by 2025. Holy cow, that's a lot. So and nursing, I'm
sorry, I didn't mean to interrupt, but when you add in that the national labor standards are showing, the federal labor standards are starting to show that EMT paramedic in that top 5 workforce area where there is going to be shortages over the next 10 to 20 years. So, we realize that some of this research is nursing research, but when you start thinking about how it correlates to EMS, when you look at the Bureau of Labor Standards and their thought process, how they're looking at the top 5 areas where the national workforce is going to have shortages, nursing was in there, but so was EMS. And in fact, we were higher. I believe the last time I looked, we were 3rd or 4th, and nursing was 5th. So, if you're an EMS director or a manager, and you're looking at how am I going to maintain the current workforce that I have and keep them competent while I'm onboarding new medics and new AEMTs and EMTs, that process is difficult. And how do you know when you're pulling these medics in and you're hiring them, they're competent? You have to do evaluations on them to determine their competency, and then have a process to maintain that competency. So this thought process that many of us older I should say seasoned.
Thank you.
EMS personnel remember being told, well, you know, if you don't like it, there's 50 of you waiting for the job. That thought process isn't there as much as it used to be. Maintaining good employees is cost effective. Maintaining qualified employees is cost effective. So from the field perspective, from the provider perspective, keeping their current workforce competent and improving their skills is a big part of that need that's out there that many paramedic programs can partner with agencies to help develop that and help support that.
I agree, John. That's a great point. Thanks. So their solution was, I mean, and a lot of times for those of you that are not nurses, John and I are, although we don't always claim it, right? Their solution is, instead of trying to find, you know, experienced nurses in the critical care, ER, and all that stuff, their solution is to use new graduates to fill vacancies. And I thought, what? Are you kidding me? I had to work a year on the floor because before I got to go to one of the units, and I was an EMTI at the time, so I didn't like that. But they pose some interesting theories, and one of them is that you can do this if you follow a process that they have. It's a 4-step process. Number one is they do have a traditional one-to-one preceptor support model, which nursing has always used. They also do cohort hiring, and I know some EMS agencies and fire agencies do that as well. Monitor progression to competence. Wow, that's kind of different. For any of you nursing theory buffs, when I did my dissertation, I did it on predictors of success on the National Registry Cognitive Examination. And that's one of the theories. I actually used a nursing theory for that, and it's Benner's theory of novice to expert. If any of you like theory, you might want to look that one up sometime. It's Patricia Benner, again, from novice to expert. Very, very interesting, and it really has a lot of use for us in EMS as well. And finally, the fourth facet was using simulation. Again, you can't always, if you want to train someone on heart failure, you may not have a patient come in that day with heart failure. So you can do that with simulation. Their rationale is that they believe that by onboarding new graduates, and this is a quote, it gives them the ability to create and influence the values and professional practice of the novice nurse as a desired advantage. So I thought about that for a minute. I said, wow, that's actually kind of interesting. Because let's face it, sometimes with different life experiences, working at different agencies, things like that, we kind of tend to get a little, I don't want to say burned out, but, you know, we kind of have our set ideas on things. And no matter what agency you go to work for, you might say, well, you know what, this is the way I've done it. I'm always going to do it this way. And, you know, you're kind of stuck in a rut, I'll say. And so that's why they're looking now to onboard these new graduates right out of school, but they're actually giving them an internship or a professional internship. And they're following them through anywhere from 6 months to a year. Now, yeah, I know you're going to say, whoa, I can't wait that long for my agency to put someone on board. No, I'm not saying we need that much time, but we just don't want to throw them out on the street either, right? So why not for EMS? Why can't we do this? Well, most of us do have the field training officer concept, so we have this in place already. Cohort hiring, some places do, some places don't. But even in education, we're seeing that people who come in as a cohort, train together as a cohort, tend to do better in the long term. Again, monitoring progression to competence is very, very important. That's a job that usually the training officers will do. And finally, with simulation, which is why we're here talking about this today. Anything you want to put in, John?
No, we can move on.
Okay, so some things to consider. Simulation is not just for assessing competency of new personnel. There's so much we can do for our employees just to keep them up to task on some of the new things that are coming down the road. New pieces of equipment, new techniques. You can also use simulation to help assess new pieces of equipment. For example, when our system was looking at a new ventilator, they actually came over, used our high fidelity simulator, put our mannequin on the ventilator, and tested out different ventilators to see which one they liked the best. What a great way to do it! You get, I think there were 3 or 4 different ventilators on the high fidelity simulator, and it helped them choose the right one. So that's one thing that you can do with it. Use it for remediation. I mean, nothing is worse than when you have a bad outcome, patient outcome. I mean, everybody is, you know, just torn apart with that. So some suggestions that many of these articles had. If possible, have your medical director be part of your facilitation or remediation team. Very, very important, because remember, that's whose license we're working under. Discuss the call initially and get input from the entire crew. Yes, some people will do that, but if you're familiar with the concept of crew resource management, you know, you've got that Swiss cheese effect, you know, a bunch of near misses leads to a bad outcome. So try and get the whole crew together when you're doing remediation. Once you've discussed the call, you've gotten some input, go ahead and run that call with simulation. Because when things are calmer, you know, you've been away from it for a little bit, sometimes education is the best, where they say, oh shoot, I didn't realize this happened, or I didn't see that, or in the heat of the moment, you know, this was missed. And then with using crew resource management techniques, allow the crew to identify areas for improvement, obviously with input from the medical director as needed. Again, once that's done, you have time for discussion. And again, we all know how important the feedback debriefing is. Rerun that scenario again after the discussion of the lessons learned, because you always want to end a remediation on a positive note whenever possible. John, anything you want to add to that?
Sure. And, you know, for those of us instructors who are in the simulation and are constantly looking for ways to make scenarios more realistic and make scenarios more applicable to the field, this is the way to do that. Take those real calls, good and bad, and design them into a scenario so that they can be used with simulation. Whether that's with a standardized patient or a high or medium fidelity mannequin will be determined by what you have available. But the point is that you can take these scenarios that have been glitch scenarios, or scenarios that should have been a glitch scenario but ran very smooth, and create learning processes from those. I always, as a medic instructor in a preliminary program and primary program, always liked to provide real scenarios and be able to say up front, this was a real scenario, here's what happened, here's what the crew did, let's get on the mannequin, let's run this scenario and see what we feel, what you feel as up and coming medics this process produced. And you know, writing scenarios can be difficult, and everybody, you know, the National Registry and NMC have had scenario writing workshops, and people are learning how to write these better and better and better and better. But from my perspective, I always tell people at those workshops, if you can start with a real scenario and put it in the format, it's a great learning experience.
Absolutely, I agree. So think about that, and think about applying that to in your training program or continuing education or remediation, and see how it goes. Now, again, we already mentioned this briefly, but we need to think about using simulation for periodic competency assessment of current personnel. There is nothing that your insurers like better than to be able to demonstrate competency via psychomotor, affective, and cognitive evaluations. Gone are the days where you get a piece of paper, you know, say, okay, we're going to give you a test, and then they said, all right, you're now competent in this. No, we all know that we tend to be very kinesthetic, visual type of people, or kinesthetic auditory for the most of us. That hits most of us, so we have to do things in order to learn and to retain. So think about that for periodic competency assessment of current personnel. And again, your insurers will be very happy when you do that. Again, develop a scenario based on your QA data and run it as simulation. Again, like John already said, your best scenarios are going to be from real calls. And you know, you've got all the data right there, and it's just going to be more interesting to your employees. Now, we talked about this, actually, the way we came up with this idea actually was from one of the lightning rounds this past symposium in DC. I was doing lightning rounds on this and got some really great feedback from a lot of you. I hope some of you are on this webinar today. Randomly dispatch a crew to a public assist call and have a simulator set up, because you all know how public assist calls happen, right? Oh yeah, we got a public assist, guy needs help getting back in bed, and it turns out he's had a stroke. So what you think initially is, nothing, we're just going to get him back to bed. We all know that's not always how it works. Again, we don't want people running code 3 or red lights and siren to any place, because we don't want to risk anybody's life. that's why the thought came up as, hey, send me to a public assist call. And you don't obviously want them to have any idea that they're going to be running a simulation call. Have the crew run that call from start to finish, including submitting a PCR. What's one of the problems that we have with our employees is poor PCR documentation skills. We hear that from our employers, from our students too, and trust me, we spend an enormous amount of time on it. But that is one of the biggies that is still out there. So yeah, treat it like a real call, because it is a real call. And if you have the ability to do this, actually have them transport the patient somewhere. For example, back to your training facility. Hospital ERs a lot of time, because you know interdisciplinary education is all the rage right now, and really it's a fabulous way to build good relationships with your centers of interest, and just really get everyone on the same page. Hospital ERs sometimes, especially in the earlier part of the day when things may be slow, they may be willing to do this, and it's a good experience for them too. Or someplace where your medical director or his or her designee can interact with a crew and patient. The benefit of this is not only do you see what patient care is on the scene, you can also evaluate the care that your patient is getting during transport, and you can also observe transfer of care. For any of you that have reviewed the literature or attended symposium, you know that a lot of times when we have breakdowns in patient care, it happens during the transfer of care. So again, you have multiple learning opportunities here, plus the added benefit of working with other colleagues in other parts of the healthcare system and improving relationships. And let's face it, that's certainly important, and certainly will go a long way in making our patient care better.
So, and keep in mind that there's a lot of things that can contribute to your ability to do some of this. For example, if you're a provider agency, get with your local EMS education program, your local college program, your medic and EMT programs, your advanced EMT programs. Worked with them to, after all, their students are probably riding with you, so you want to make sure you get good students. But on the other hand, as you're trying to provide continuing education and assessments on your staff, your personnel, they may be able to help with that, especially if they have the high fidelity simulators that you may not be able to afford. Maybe you can work out some sort of deal with them. I want to reiterate something that Dr. Stepanovsky said about interdisciplinary scenarios, because it's very, very important to understand that not only is it the rage, but think about all of the groups that your medics, your EMTs, your advanced EMTs interact with. The fire and EMS, law enforcement, your ER staffs. If you happen to work in an area that allows non-emergent stuff to go to urgent cares, there's urgent cares. Pickups at doctor's offices when there's an emergency in a doctor's office. If you work in an area that has some of the natural birthing centers, and of course clinics, nursing homes, ALFs, and all the other areas where we pick up, that doesn't mean that you can't run scenarios with these people. I have been very, very surprised, especially birthing centers and physicians' offices, when the programs have approached them and said, well, we'd like to run these scenarios. We'll run it for your people before the EMS crew gets there, and then we'll have our crew do it. So they're getting education, and a lot of times they will jump into that, and let's face it, sometimes they'll share the cost with you too, and that helps your agencies do that. The other concern that a lot of agencies have, and we've all seen this, new equipment's purchased, somebody goes to a conference and decides this monitor's better, this intubation, this ET tube's better, this tourniquet's better. And then, they're purchased and they're dropped on the truck. Well, these days, we see more and more where equipment education or equipment onboarding, if you will, it has to occur. And simulations are a good way to do this, because it's not just, here's a tourniquet, or here's a monitor, or here's a new ventilator. It turns on this way, you do this. They have to use it in the simulation. So they get the classroom on it, and then they get hands-on in a practical situation. That is extremely useful in not only onboarding new equipment, but if you're going to look at what you want to purchase, the salespeople are more than happy to bring you a demo. Let them bring you a demo and run some simulations with it. Get a feel for how it really works by using it.
Absolutely, John. Great point. Thank you. We have also had some opportunities to work with medical schools, and John can talk a little bit about that too. He's with his role at USF. But I also teach as an adjunct for a chiropractic program, and I teach their office emergencies. We ran some interdisciplinary scenarios with them. Wow, what a benefit it was, and the students love it, and your agencies will love it too. Again, the other thing is you get to learn a little bit about other professions and some of our partners in healthcare. So lots and lots of advantages there.
You know, and you know, I'm sorry. So the concept of a standardized patient. People say, well, you know, I can't afford the real a standardized patient. I can't afford to have all of this thing because it's too expensive, and I'm not able to do that. Well, one of the things that's important to understand is there are ways around that, and one of those ways is senior centers, college and high school drama clubs are readily out there. Now, are you going to do advanced procedures on them? No, but you know, the one of the new and upcoming things in simulation right now is wearable simulators. Okay, where you can purchase these simulators that standardized patients can wear, so IVs can be started. And in fact, I was just recently at Symposium, and there was a vendor there who had a trach mannequin that not only could we practice us creating surgical crikes, but for patients who are already had trachs in, you could simulate this by putting it on a standardized patient. You could simulate blockages, you can simulate tube changes, and those types of things. So these wearable simulators are starting to become more and more active, and we're seeing more and more companies produce them. And so that opportunity to be able to use the standardized patient in that process is really important. And let's not forget about auxiliaries and Fire and EMS Explorer and cadet programs. They need their community service hours, and it's always good if we can use some younger people. We're really good at using adults and even the older people, but we all know pediatric calls are the ones that make us, really struggle for many EMTs, advanced EMTs and medics. So this is a great way to get them some pediatrics in the process. And let's not forget, EMS Explorers, cadet programs, and even high school students, they want to see what the job is like. You never know when you're producing a recruiting effort for the next hire for your agency or the next medic student for your paramedic program. All right, so I think the next thing we'll move on to is the benefits of simulation.
Sorry, I muted myself. One of the best things I ever heard was from Lou Oberndorf, who at the time was the CEO of METI. And I just love this, and I've never forgotten it. And he said, simulation is about the suspension of disbelief. And when John was talking about the wearable simulation, I was thinking, that's definitely the area that we're moving into. And I think that's what it's about. When you see one of the folks that are in your simulation start sweating, I always think, wow, this is a good simulation because they're actually, it's real to them. So great thing to do. Okay, so some benefits of simulation. Again, lots and lots in the literature. But again, how can we improve the effectiveness of simulation-based training? Well, this I thought was really interesting. And the anesthesiologist, as well as one of the other articles that I'm going to share with you later, actually talks about this in great length. And they're saying that we really need to focus more on the training of simulation instructors and facilitators. Because as John mentioned in the super study, a lot of people don't even use their simulators and equipment because they don't know how. And the majority of people get their training from the manufacturer of that one product. So this training of the simulation instructors and facilitators really needs to be highlighted. And John, I'm going to turn this part over to you.
Okay, so when you look at, okay, how do I get them trained? There's all kinds of training programs out there. There's programs by the companies that sell simulators. There are now degree programs. There are certificate programs, and there is even now certifications for simulation educators, healthcare simulation educators, and healthcare simulation techs through the Society for Simulation in Healthcare. SSH, which has some great opportunities out there. And there's a lot of local stuff too. We have a simulation healthcare co-op in Florida. Many states have started developing these co-ops where organizations support each other in helping to develop these training programs. And the other thing that you know, the research shows is you have to optimize the simulation in the curriculum itself. It has to be buried into the lesson plans. It has to be buried into the curriculum in order for it to work. Whether that's initial training and we're following, you know, the national educational guidelines, or whether that's continuing education and you're using those guidelines, but you're also using your protocols and your medical director's process for best practices. Simulation is a way to help move those things forward, to move protocol changes, to move best practices. And it allows for ongoing training. It allows you to build one session on the next session on the next session. One thing I do want to just kind of remind people of, try not to tunnel vision in on a specific simulator or a specific process for doing simulation. I tell people all the time I'm a really big advocate of standardized patients. However, I'm also an advocate of high fidelity simulators and medium fidelity simulators and skills mannequins, because you need to be able to build a student up in that process. So try not to, you know, to focus in on a single piece of equipment or a single process. We want that suspension of disbelief, but we need to get them built to that point before we can start moving towards that. The other area that there's huge benefit in using simulation is communication. Improving communication of crews with each other, improving communication of crews with the ER on their turnovers. And if you work in a two-tier system, that turnover between tier 1 and tier 2, the first response and the transport turnover, that area is where the areas of communications tend to have issues. So the ability to be able to practice that improves communication. It also improves agency cooperation if you're doing interagency and interdisciplinary continuing education using simulation. So that kind of brings us to our next topic, which is costs and time. And Nerina, if you could change that, thank you. There's no doubt, I can vouch for that because I'm responsible for purchasing in my center, that simulation is expensive. So, you know, there's lots of things you can do. Partner with your schools, you know, joint purchasing. I will tell you, there are a lot of agencies, especially out west, that when they're hospital-based EMS systems, they are so lucky because they have the ability to tap into the excuse me, the hospital's simulation programs. That doesn't mean if you're not a hospital-based system, you can't do that. Look at what your local hospitals are doing. Where are you responding? Where are you taking patients to? Can you develop joint training programs to them? Many simulation centers, if you're running a medic program and you have a simulation center at your school, whether it's strictly for your medic program or it's interdisciplinary, they have hours during the week that they'll contract those centers out. So you may be able to lower your cost by purchasing time in an established center that has a medical background, that has a medic program and medic faculty that can help improve your education process. So these partnering programs and partnering with medical education and medic programs and interdisciplinary education, they can not only strengthen your simulation program, but they can deeply reduce your costs. And anybody who wants to talk costs and time analysis and any of that, at the end of the presentation will be my email. I'll be happy to one-on-one with you because we're all concerned about that. And I know, you know, especially if you're trying to start a program. So with that, I'm going to turn references over to Dr. Stepanovsky, and then we'll get to your questions.
And again, thank you, John. I wanted to note this last bullet in that, you know, there really is a need for a national train the trainer program because, yes, simulation is a wonderful, wonderful tool, but it, again, as John said, it's really part of a whole packet of teaching. And if we can get a standardized approach, you know, in the way educators are trained, I think simulation is going to be a lot better. And again, I've listed that reference. And I too, if I can help, I'm certainly happy to help in any way. So I've listed for you here the references. These will be available to you. You can also email me if you need these or if you didn't catch them. And again, it will be on the webinar when it's repeated. These are probably the best of what I had reviewed so far. And of course, we did have the super study listed on there as well. So at this point, I think we'd like to open it up to questions.
Yeah, I don't see any that have come in, but everyone should know that they can. On the right side there, you can post any question that you may have for our presenters right now. I figure we might give it a few minutes if you guys wanted to reiterate anything in the meantime or make any additional
actually,
comments.
while we're waiting to see if anybody has any questions, I want to emphasize this whole train the trainer process. There's a lot of really good programs out there. There's all kinds of healthcare simulation education programs, and you don't necessarily need to be EMS specific on this, because the education process of integrating simulation in the overall profession of healthcare is pretty solidly the same. I mean, the research shows everywhere that training and curriculum development, training and integrating simulation into curriculums, scenario design. We all know, as I said earlier, that the National Registry and NEMC have been working diligently for the last 2 years on scenario development workshops and helping people develop scenarios. That's all a part of this education. And again, I want to reiterate the Society for Simulation in Healthcare, which I have no direct responsibility for, or other than being a member. They have some great programs on this. They have recently started an EMS affinity group within the organization. So now there's a group of educators who are specifically EMS educators who are having discussions and looking to provide EMS-based simulation education at their conference, as well as other conferences out there. So there's lots of opportunities. Again, our contact information is on the screen. I will be happy to talk to anyone, as would Dr. Stepanovsky. And if there's something we can't answer, we'll give you a reference to where you can get answer to, or we'll send you whatever articles or research that we know of. One last thing for me, I kind of stand on the fence between nursing and EMS right now, and I will tell you, people could say education is education, but healthcare education is different in some ways. But a lot of the research that nursing has done through the NLN, through INACSL, the International Society for Nursing Education and Simulation, can be correlated for EMS, especially the clinical information, excuse me, and the ability to be able to substitute that for onboarding personnel. So lots of good information out there, and we'll be happy to get you connected to it. Dr. Stepanovsky, any closing thoughts for you? Well, Nerina, I think maybe your microphone's having some issues. Brandon, did we get any questions?
We did, yes. We got a couple
Okay.
here. The first one that came in was, as far as train the trainer, is NEMC developing something?
Well, I'm glad somebody asked that, because the answer to that is yes. We are currently working with our simulation committee, is working on a couple of different projects, and we hopefully will have a program out soon that'll be at least for entry level, and look for that on the website. Look for that at Symposium this coming year in DC. So the answer to the question is yes, we are working on it, and we're diligently working to get it out as quickly as possible. But we want to make sure it's solid and it's appropriate before we release it. But the answer is yes.
And then the next question is, can you explain your definition of high versus medium fidelity?
Okay. When we're talking about fidelity, one of the important things to understand is fidelity is about how well the student thinks of the realism of the process. So how well they are immersed. So when we talk about medium fidelity, some of us may remember the old Leardahl ALS mannequins. You could do EKGs on, put your monitor on them, and you could do EKGs, and you could start an IV. but the mannequin didn't respond, the instructor or the operator wasn't wearing a headset, so the interaction wasn't there. Those are kind of considered the medium fidelity. High fidelity are those that help suspend disbelief a little bit more. So mannequins or simulators that provide heart sounds, lung sounds, the ability to establish IVs, give medications, have the mannequin respond, move the mannequin. One of the things that used to be a big complaint was they were tied down to generators and gas tanks and these types of things, and now we have simulators that are completely wireless and can be put in the back of a unit and can be put on the ground, and that sort of thing. So the difference in fidelity is how realistic can you use the simulator to create an environment to immerse the student in. So think of it this way. So mild to no fidelity would be the skills simulator, the intubation head, where we just go in and practice. High fidelity on that end would be a simulator that could go in the respiratory arrest, can have a swollen tongue or a tongue of different sizes, allows the neck to be stiffened or to be loosened, allows the jaw to be stiffened, so that you can create these environments that increase or decrease difficulty. The ability to immerse your students in the simulation is directly related to how your fidelity is, not only in the equipment, but in the simulation environment itself. I'm notorious, and people know this, for adding smells and sounds and changing the level of light or darkness in a room for a simulator, especially in my EMS simulations, because we don't work in clean environments. We work in these environments that are uncomfortable, that are dark, that are wet. So adding that adds to the realism, which increases the fidelity of the simulation.
And then
another question?
The last question. Yep, the last one I have here is, what do you do to evaluate the effectiveness of simulation training? Do you have a rubric, etc.?
Okay, there are some really great rubrics out there. In my center, we use the INAXL, the International Society for Nursing Simulation Education. They have a really good evaluation rubric, which is free on their website. We have an adaptation of that. The NLN also has a really good one. But I will tell you, most medic programs have really good evaluation rubrics. If you're using a good evaluation rubric on your skills lab and on the scenarios you're already doing, there's a good chance that you could just tweak that a little bit, and maybe look at the INAXL one or the NLN one and tweak it a little bit to get your rubric or your evaluation process to work. If you don't have one, these are great places to start for that. Also, the registry has some really good starting places for you to be able to build those. And don't forget, we're not only evaluating students, or you have to evaluate the faculty and the presentation of the scenario as well. So, I like to see agencies and schools using rubrics to do those evaluations as well. We evaluate the student, we evaluate the education we provide, so that we can make sure we give good, solid education in the end result of that.
And that was the last question.
All right. Well, it looks like on my calendar we're 2 minutes of. So great on timing. I'd like to thank everyone who logged on and stayed with us through this presentation. And keep in mind, if you have some fellow member educators who were not able to sit through this, eventually this will be available on the NEMC website for re-review. I'd like to thank Dr. Stepanovsky for working with me on this project and including me on the project, and remind everybody that symposium, the National Association of EMS Educators Symposium, is July 30th through August 4th in 2018 at the Omni Sharham in Washington, D.C. And there'll be lots of simulation there, as there was this past year, lots of simulation education, both as pre-cons and in the program itself. And Dr. Stepanovsky and myself both look forward to meeting some of you in person at Symposium. Dr. Stepanovsky, any closing thoughts? Is your mic still down? Okay. All righty. Well, for Dr. Stepanovsky and myself, again, thank you. And anybody have any questions, please don't hesitate to email us.
Great. Thank you guys very much. And yes, thank you to everybody that joined us. Look for this on the website if you're an MZ member. And if not, please give us a call. We'd love to talk to you. So thank you guys very much. Thank you, John. Thank you, Nerina. And we hope that the rest of you have a very lovely afternoon.